All right, welcome to the final part of our series on vestibular neuritis. We've already covered diagnosis and acute treatment, so now we're going to focus on what is, for your patient, the most important phase of all, the path to full recovery. Okay, let's dive right in with a clinical pearl that really frames our entire approach to rehab. It sounds a bit backwards, I know, but a dizzy session is a productive session. See, the brain only learns to recalibrate to these new signals from the inner ear when it's actually challenged. Avoiding movement, avoiding that dizziness, that just prolongs the whole recovery process. This is the core idea we have to get across to our patients. So here's our plan for this explainer. We'll start by looking at what a typical recovery looks like, then we'll jump into the 4 active phases of rehab. After that, we'll highlight 3 really high-impact actions you can take, cover 2 common bumps in the road to watch out for, and then we'll wrap it all up. First up, let's get a really clear picture of the natural history of this condition. Managing your patient's expectations right from the get-go is absolutely crucial for a good outcome. And the good news is that yes, recovery is the rule. That really intense constant vertigo they feel at rest, that usually settles down within a couple of weeks, maybe up to 4. But that motion-provoked dizziness, that feeling of unsteadiness when they turn their head or walk around, that can take a bit longer, maybe 2 to 3 months to fully resolve. Making that distinction is so important for reassuring them.
Now, this is where it gets really interesting. This slide shows that recovery isn't just about the inner ear healing itself. Actually, only about half of patients ever get full function back in that affected nerve. The other half, well, they recover because their brain adapts in this incredible process called central compensation. So you see, recovery is an active process of the brain literally rewiring itself, not just passively waiting for a nerve to heal.
We also have to be on the lookout for things that can slow down recovery. Some of these are fixed, right, like older age or other health conditions, but a few of them are highly modifiable, and this is where we come in. Things like delaying rehab or, and this is a big one, the prolonged use of vestibular suppressants. This is where our management can truly change the game.
So how do we actively guide this recovery? Well, it all comes down to a structured 4-phase rehabilitation program that really empowers the patient to drive their own central compensation.
And this timeline just lays out that whole journey perfectly. It shows how we progress the patient from that really acute stage through early rehab and progression, and all the way to getting them back into the community and living their normal life. Let's break down each phase, one by one.
So in the first 3 days, the absolute priority is getting those severe symptoms under control. This means using antiemetics, but only if they're really needed and for less than 72 hours. And of course, starting corticosteroids if they present early. But what's critical here is that as soon as they can tolerate it, we introduce gentle, deliberate head and eye movements to kickstart that compensation process.
Okay, now we're into the first couple of weeks, and the number 1 rule here, and this is non-negotiable for recovery, is to stop all vestibular suppressants. Then, we begin active gaze stabilization exercises, and we get the patient up and moving with some supervised balance and walking practice.
Over the next several weeks, we basically dial up the intensity. The exercises get more complex, like turning their head while they're walking. We introduce habituation drills that deliberately provoke a little bit of dizziness to build up their tolerance. And we challenge their balance by having them stand on soft surfaces or in a tandem stance. And the final phase is all about applying these gains to the real world. This means practicing in visually complex places, like a busy supermarket. It means getting back to normal activities like driving. And, importantly for us, it means reassessing for those common long-term complications that can pop up. So, with all that we've just discussed, let's really zero in on the most important point. Where can you, as the clinician, make the biggest possible impact? What are the key things that will most improve your patient's long-term outcome? It really boils down to 3 simple modifiable factors. These are the levers you can pull that can change the entire trajectory of their recovery. And here they are. Number 1, get them started on rehab within the first week. Number 2, limit those vestibular suppressants to an absolute maximum of 72 hours. And number 3, actively encourage mobilization and discourage prolonged bed rest. These 3 actions, these are your most powerful tools. Now, let's talk about what happens when recovery isn't quite so straightforward. It's so important to recognize 2 common complications that can pop up. The first is benign paroxysmal positional vertigo, or BPPV, and the second is persistent postural perceptual dizziness, or PPPD. This is a question you will definitely face. A patient is getting better, and then they develop new symptoms. This isn't a failure of rehab. It's usually a sign that a new, distinct, and highly treatable condition has just emerged. And this chart illustrates the two main culprits perfectly. On the left, you've got secondary BPPV, which happens in about 10 to 15% of patients. Think of this as a hardware problem. Little crystals in the inner ear get knocked loose, and it's fixed with a simple mechanical maneuver. On the right, PPPD is actually more common, affecting up to 30%. This is more of a software problem. The brain's central processing has become maladaptive, and it requires a totally different approach.
So if your patient reports new, short-lived spinning spells when they roll over in bed or look up at a high shelf, you have to think of BPPV. The key is to re-examine with a Dix-Hallpike test at every single follow-up visit. And remember, this is not a setback. It's a brand new, very treatable problem. On the other hand, if their dizziness becomes this chronic, lingering thing, lasting more than 3 months, and it's more of a nonspecific feeling of unsteadiness that gets worse when they're upright or in a visually busy place like a supermarket aisle, you need to consider PPPD. This is the single most common reason for a poor long-term outcome, and it needs its own dedicated management plan.
Okay, let's bring it all home. We'll summarize the key practice-changing points and then wrap up our entire 3-part series.
Here are the crucial takeaways for your practice. First, set expectations. Recovery usually takes 2 to 3 months. Second, be active with those 3 levers. Third, you've got to systematically screen for BPPV at every follow-up. And finally, always maintain a high index of suspicion. A diagnosis of recurrent labyrinthitis is almost never correct. And as one last critical reminder, any new episode of acute vestibular syndrome demands that you reconsider a stroke. And that completes our journey. We started with using the HINTS Plus exam to confidently diagnose a peripheral syndrome and rule out a stroke. We then walked through the evidence-based acute management plan, and today we've navigated the full recovery pathway, including how to handle those common complications. Thank you so much for joining us. To help you put all of this into practice, we've got one-page summaries and patient handouts available on our website. And if this series has been valuable for you, please subscribe so you don't miss any of our future explainers.